Okay, welcome everyone. I'm here to introduce you to the session on tips for co-prescribing in concurrent disorders. So welcome to Valerie Primeau, who is here for this excellent talk we're all excited for. So she is a bilingual psychiatrist in North Bay who has been actively involved in the treatment of concurrent disorders. She is the physician lead for the implementation of medically supervised withdrawal management at the North Bay Regional Health Center and the rural implementation of the CAMH integrated care pathway on alcohol use disorder and depression. She sits on the executive committee of the Ontario Psychiatric Association and is currently the North Bay co-site director and psychotherapy coordinator for the Northern Ontario School of Medicine Psychiatric Residency Program. So lots of knowledge to share with us today.
Thank you for the introduction, Katie. My hope is to kind of show you some tips that I use in my day-to-day prescribing in concurrent disorders. You've heard my bio, so I do a lot of concurrent disorder work. I've left a couple things. I've left my email. I've left my cell phone because one of the myths is that psychiatrists aren't able to be reachable or don't want to, give advice or things like that because they're too busy and whatnot. Well, there you go. You have my cell phone, so you can text me anytime if you have questions about concurrent disorders. I want to be as approachable as possible. I also left a website link, which just has a file directory of presentations I've done in the past. I will also upload these slides in PDF as well. There's other info on there about concurrent disorders if you want to go. It's not a special website. It's just a file folder where you can pick up some resources. All right, let's see if I can move my slides now. Okay, perfect. I have no conflicts of interest. I am a very poor psychiatrist. I have no sponsorship with any pharmaceutical companies, so I don't have to worry about that. These are the objectives of the session, which you already be familiar with if you saw them in the program, but I'm going to try to cover these during my presentation. Great. So I've divided in 5 major tips. I'm hoping to spend about 45 minutes on the tips, and then we have the rest of the 50 minutes for discussion. So at least not a code white. I like it that some other people understand the life of a psychiatrist there. Yes, at least it wasn't a code white. And it's not my patient that's running away, so that's good. So the tip number 1 is screen, screen, and screen. So I wanted to spend about 5 minutes on screening because one of the things that I've noticed from my colleagues is that often people just don't ask the right questions. They don't ask about either mental health symptoms when people have addiction issues or vice versa. If people have mental health symptoms, they don't ask about addiction issues. So we're just going to run you through some numbers that justify why the two are very intertwined, first of all, and also what are some of the tools that I use to screen in my practice. We do know from many studies, starting back from the ECA study, which was a huge epidemiological study in 1988, and more recent numbers, including Canadian numbers, that substance use disorders and mental illness are very interlinked. So we do know that people that have substance use disorders are more likely to have mental illness, and vice versa. People who have mental health disorders are more likely to have substance use disorders. And it is definitely much higher than the regular population. We also have found out that if you have mental illness, you're more likely to develop both alcohol and drug use disorders together rather than just one or the other. And the odds are quite higher compared to the normal population. This is a table from the Journal of Psychiatry, the Canadian Journal of Psychiatry, that shows, again, similar odds ratio. And for people who aren't familiar with odds ratio, it just essentially tells you that this is the amount of times that it's higher than the normal population. So in this case here, patients are more likely to have substance use problems than the normal population, up to, depending on which disorder it is, up to 5-6 times the normal. I wanted to touch base about alcohol, especially with COVID-19 right now. Alcohol use disorder is definitely a major issue right now, and it remains by far what I see the most in my practice as a concurrent disorder physician. The Canadian numbers definitely show that this is an area that we need to continue focusing on in addition to the other substance use disorders. And I wanted to give you some numbers again that reinforce that we need to screen for alcohol use disorder and substance use disorder regularly. Here's another slide that showed the interplay between substance use and mental illness. So this is the slide regarding alcohol use disorder and depressive symptoms. So the majority of patients actually that use alcohol have depressive symptoms. and the severity of the symptoms is usually quite high compared to people who do not use or have an issue with alcohol use disorder. So again, showing that connectivity. We'll take the questions at the end, but somebody just mentioned about stats on co-occurring complex PTSD, and I could definitely forward you some extra information after the talk, but definitely PTSD and substance use disorder are very comorbid as well, definitely. So I'm happy to forward you some info on that afterwards. So in terms of screening, especially with major depressive disorder and alcohol use disorder, which has been a major focus of mine over the years, there's definitely a big link between the two. We also believe that there's causality link between MDD and AUD, and that they are routinely undertreated, unfortunately, in the communities. So it is important to know how to recognize them, and that every time you see a patient, it's an opportunity to ask for those disorders. And we do know that combining different approaches, including medication, psychotherapy, and medication for both alcohol use disorder and depression, for example, is going to be more effective than using only one modality alone. So here are some of the kind of most common errors that I've seen. I have been taught a lot of different physicians over the years regarding this, and some of the errors that I've made when I was in training as well. Often it's just not asking. We don't ask about the consumption of alcohol, cannabis, or illicit drug use, or we accept vague answers such as, I just do it occasionally, I do it with friends, I drink socially, and what they mean is actually I get a 26er every weekend. Well, that's not just drinking socially, right? So it's important to know exactly what's going on. I also ask, how much alcohol do you drink, or how much cannabis do you use, and not say, do you drink alcohol? Because if you ask, do you drink alcohol, the likely answer that people want to say is, oh, not that much, or not too bad, right? They get a negative connotation from the idea of being asked a yes or no question. But if you say, how much alcohol do you drink? It's assumed that you do drink alcohol, and it opens that conversation a bit better. I do the same for cannabis as well. Not converting to standard amount or standard drinks. I see that both for alcohol in terms of not knowing exactly what people are using. Is it tall boys versus regular cans versus how much alcohol is in the drink they're using? Is it a big, large glass of wine? But also for other substance use disorders, when it comes to opiates or methamphetamine, is trying to get a sense of how much money they are spending and how much grams or ounces or amounts of substances they're using. And I often will go to, my colleagues in the that are on the front line to know, like, well, how much is a point of this? Like, what does that mean? How significant of a substance use is that? Because the error to make is when somebody tells you, well, I use every day, but you don't get a sense of how much, you won't be able really to predict the severity of the substance use disorder. So getting an accurate number is very helpful. We often tend to miss the bingers, the ones that tend to binge heavily for a period of time and then don't use for a couple weeks, for example, especially if we just ask, do you drink on a weekly basis? And they say no, well, then you just miss the people that could binge very heavily once a month, for example. We do, unfortunately, in the studies, we do tend to underestimate people that struggle with mental illness, whether it's due to lack of time, to not accurate screening. So we do need to be mindful of that. And we tend to forego using clinical scales. Again, this is the idea that clinical scales slow us down to measure not only the impact of drug use, cravings, but also to screen for mental health disorders. So I hope if you take one thing from this tip is that you could actually have clinical scales available in your office so that patients can actually fill them while they're waiting to see you. And it doesn't actually slow you down. If anything, you can use the info on the scales to not have to ask those questions in your interview. I put there the criteria for substance use disorder. For prescribers, this is likely something you're very knowledgeable in at this point. I do like the DSM-5 now because it merged abuse and dependence together, which makes it easier. Before, a lot of us were just kind of like, oh, it looks more severe than abuse, I'm going to rank them as dependence, and we didn't really go through the criteria. Now, with this criteria, it's just easy. You just have to make sure you know how many out of 11 they have, and then you know the severity of the substance use disorder. This is something that you could turn into a scale in your office again, that you could ask these questions to the patient, and then they could calculate how many they have automatically, and you wouldn't even have to go through it yourself. So again, using standardized measures can be really helpful to pick up on substance use disorders. This is from our government, so just reminding you of the proper low-risk drinking guidelines. They may have changed. To be honest, this was actually what I used at the OPA last year. But in general, Women should not drink more than 10 drinks per week, and it's 15 drinks for men. And again, it helps. I actually keep a colored version of that in my office to show patients, is that what your glass of wine looks like? Or is that what your shooter looks like? To make sure that we're on the same page when we talk quantities, right? Again, to get a better sense of the extent of the potential substance use. Some of the screenings I use, the cage has been there forever. You probably know about it already, but I find it's a great way to kind of just get into potentially someone that starts struggling with AUD. So that's one that I use regularly for alcohol. I also use the audit, which is a little bit more detailed. Here, this is the score. So if you do want to go get the audit and score it, you know how to score it. And like I said, I'll have a copy of my slides available. I find it helpful. It can be done by self-reports. You don't need to do it for the patient, and then give you a sense of how severe the alcohol use disorder might be. That's an example of the questions that are asked on the audit. It's quite simple for the patients to answer. Oh, I think I'm supposed to have an extra slide on a scale for measuring cravings in substance use, but it looks like it's missing. So what I'll do is I'll just upload it on my website, but I also use scales for measuring cravings as well. And there's different scale for measuring drug use as well. And it depends which one you're comfortable using. You can also add those to your arsenal as well. But I'll drop the craving scale. I don't know why it's not on my slides. Apologies for that. For major depressive disorder, the PHQ-9 is great for screening. I think most primary care providers know about it. I don't find it great for monitoring symptoms, though. I use the quids for monitoring symptoms because it's more detailed, so you'll notice variation in the symptoms more clearly, right? The PHQ-9 is only 9 items. The quids is longer than that, and it also can be done self-report. I can leave that later at the end for the craving scale. So I'll put it up while we have the questions afterwards. The HAM-D is a great scale as well for depression. The problem is it's very copyrighted and you have to purchase it. So we use it in the studies a lot. But for someone in your office by yourself, for example, who's trying to just get some screening done, I recommend the quids because it's free to use. You can go on their website and get it from them directly. You don't have to pay anything. I think I have an example of the questions in the quids. So that's an example. Again, it can be easy to done by self-report. So they just pick, it's from scales from 0 to 3, and then you add everything, and then it tells you kind of the severity of their symptoms. All right, so in order to not make it too boring, I've got some polls here. So we're going to start with poll number 1. Perfect. And I don't know how this works for you guys, but I'll give you some time to answer. So the poll is, which medication can be used to manage alcohol cravings in alcohol use disorder? Curious to see your knowledge of anti-cravings at this point. Oh, well, that's unfortunate. You can't select multiple options. So, you guys are making me sad, but that's okay. Select one, and then we'll see what the. Yeah, you're right. I can't select more than one. So I blame the platform. This is not my poll. If I were doing poll everywhere, you could have pulled more options. I answered one of them too. All right, can we pull the results of the poll? There we go. All right. So most people pick naltrexone, which is actually the one that I think most people know about, right? It has a lot of rep, if that makes sense. There was a TED talk about naltrexone as well on the internet. Definitely a medication I use regularly. We'll talk a little bit about it as well in this talk. And then other ones, baclofen, acamprosate, topiramate, gabapentin. There are all other medications we can use for AUD. Acamprosate has an official recommendation. The other 3 are what we call off-label. And then, yeah, nobody picked disulfiram. I don't know if it's because they feel it's not a medication that helps with cravings. I do feel that it helps with cravings in the sense that it deters you from using, which then decreases your cravings. But it technically, it's not a anti-craving in the proper sense. So maybe that's why people didn't pick it. And then sertraline is more to help with any associated anxiety or depressive symptoms. That's the only one I wouldn't have picked out of those as being an anti-craving. Okay, how do I get back to my slides from here? Thank you. Okay, poll number 2. Let's pull that one. So let's see what your knowledge of medications is a little bit. So for the prescribers here that use medications regularly, so if you think about medications for cardiac prevention, what would be the number needed to treat in general? And please know I'm not a family doctor, so I actually got this poll from a colleague of mine, so don't blame me if the number is not exact. But in general, from your knowledge of cardiac medication, where would the number needed to treat be? And for people who don't know what a number needed to treat is how many people do you need to have one favorable outcome out of the medication? Somebody said 112. That is very, very specific. I like it. So the last answer can be 50 or more if you think it's above 50. So. All right, let's pull the results and see where we're at. All right, so the majority of people said it's likely pretty high, like 30 to 50. Let's see. Oh, that is not the right next poll. The next poll is about the naltrexone number needed to treat. We'll get there. Oh, okay, so you're back to the results. All right, so just showing that most people think that it takes at least 30 to 50 people for one person to benefit from cardiac prevention medication. So let's switch to poll 3 now. All right, perfect. So what is it for naltrexone? Do people know the number to treat for naltrexone if you think that the cardiac number would be above 50? And we'll give about 30 seconds. All right, let's pull the results, see where we're at. All right, you guys are really well informed. The majority of people said 10, and that is correct. Actually, the number needed to treat for naltrexone is 10. So what is the moral of this? We can go back to my slides now. Thank you. Is naltrexone works really well. So my tip number 2 is every encounter is an opportunity for anti-craving therapy. There should never be a reason why, if you have a patient that has issue with alcohol use disorder, that you should not be using an anti-craving and offering it to these patients. And there's never a setting really when it wouldn't be appropriate to start it unless they're crashing in the ICU. Otherwise, it's always an opportunity to offer anti-craving therapy. The number needed to treat is one of the best in medicine, right? So you're never going to go wrong offering it. That would be my other tip as a concurrent disorder prescriber. I do not have time in this presentation to go through all the anti-cravings with you. I do have on my website my longer OPA presentation, and CPA presentations would go through the anti-cravings in much more detail, and you're free to go download those slides. But essentially, we use 3 major medications that have Health Canada indication. There's naltrexone and acamprosate, which are the ones I use more regularly, and then Antabuse has been out there forever, but we usually need someone that is quite reliable and has good supervision in order to use it, but it works really well if it is taken properly. Acamprosate had a huge backorder problem for a while, but now it is back in stock in Ontario. I've been re-prescribing it recently, so that's good news, and so far no indication it's going to go away anytime soon, knock on wood. And then we do, there are 3 off-label that I tend to try out if the first lines don't work, and that's topiramate, gabapentin. And then baclofen has also been mentioned. It has a bit less evidence, and I reviewed the American Psychiatric Association guideline. They don't mention it as one that is suggested. So I would say I would start with the first 2 off-label, the topiramate and gabapentin first. And I also mentioned where they fall in terms of hepatic or renal metabolism, because it is important to double check those things. And then, just so you know, this is more for your information, naltrexone and acamprosate cost around $6 to $10 a day. In Ontario, we do have full coverage to ODB with the LU codes now. So if you don't know those EOU codes, I left them there for you. But if a patient is not on ODB, it is pretty expensive. They don't have private benefits. So do be mindful of that. That could be a reason why you'd rather go off-label if they can't afford naltrexone or camprosate. In terms of general advice I give to patients that are going to be on an anti-craving, I just make sure to let them know that the medication helps reduce your cravings, but will not actually change the effects of the alcohol otherwise, unless it's antabuse, because antabuse blocks the metabolism of alcohol, meaning you will still have impairment from alcohol. It will not sober you up or anything like that. Oh, somebody is saying they can't see the slide properly. Is that something we're having issue elsewhere, or? If anybody else has any other technical issue, okay, it looks like it might be on your end. So I just remind people that anti-cravings are not going to help them sober up or mitigate the effects of alcohol, but it does help reduce the pleasure of the alcohol that you get from the alcohol, or it will help rebalance your chemicals after you drink. So for example, the balance of GABA and glutamate, and that's how a camprosate works. A lot of people ask me, how do I know if it's working or not working? I just use the low risk drinking guidelines as a guide. So if patients are still above those, then I look at increasing the dose of the anti-craving, combining or switching to another one. Another question I get a lot is, how long do I keep people on an anti-craving medication? My recommendation is at least 6 to 12 months. Although some patients can stay on them for years, they are very well tolerated, especially naltrexone and camprosate. They're not addictive. There's no weight gain or major sedation or anything like that. So some people will stay on them long term or use them as needed. Like naltrexone can be great as needed if somebody, for example, has binges and they don't have to be on them every day. But I find that most people can benefit from a good course of 6 months. These are indication when you might want to stop anti-craving therapy. So I left that for you. There needs to be a change in the patient, right? Either their environment has changed, they have better coping strategy, they're no longer in contact with people who use alcohol as much. Something needs to happen for them to be able to come off the anti-craving, or else they might be in the same position once they stop it. I just want to say the discussion is awesome on the forum chat. It's hard to want to stay away. So this is an example of what's in my slides. If you go to my website, what I do is I go through every anti-craving and I talk to you about the dosages, the interactions, and how it works, as well as the major side effects. I don't have time to go through that today, but if you're interested in the information, and yes, some people are asking about naltrexone. So I have gone up to 150 with naltrexone. And the main thing is to check the liver enzymes, right? For naltrexone, which I also have the monitoring on my second slide. And again, I have that for each of the anti-craving. I won't cover that today, but if you're interested in knowing more, that's the for naltrexone. As you can see, the side effect profile is really good. You just have to make sure you check their liver panel. For camprosate, it's always a very interesting dosage. I call it the evil medication against alcohol, of course, because it's 666. So that's the only drawback, is that 3 times a day. Some of my patients find that tough to take it 3 times a day, but it is renally excreted, which is really nice, and it doesn't interact with anything. And all you have to do is check their liver profile, and then you have to adjust if they have renal impairment. Again, the adverse effect profile is quite good for a camprosate. I won't go through the off-label, but again, feel free to check them out on my website. I'm going to move on to tip number 3. We're going to get the 4th poll going. Tech team, are we loading poll number 4? Here we go. All right. So I'm going to, actually that's poll number 5. There we go. All right, perfect. Okay, so poll number 4 is just a scenario you may have seen in your practice. So it's about a patient with longitudinal history of depressive symptoms. And of course, you can't tell, and they can't tell, did the alcohol come first? Did the depression come first? So what do you do in this kind of situation, right? I get that all the time in my practice. Do you start with the depression or the alcohol? And I will post, while people are answering the poll, I will post my website again, and so that people have it. Oh, and again, it's not a fancy website, but it has the resources. I actually can web design, but I have had no time to do that. Can we put the poll results? Thank you. Great. So the majority, it looks like we were split between offering an anti-craving and reassessing for antidepressant after 3 to 6 months. And that's how I was trained, by the way, when I was in residency, is kind of help people get off the alcohol or the substance that they're abusing and then reassess for depression afterwards. And then number 2, which was also actually the most popular, was offer anti-craving and antidepressant at the same time. That is my recommendation, is if you cannot tell really what came first, what came after, and they have significant depressive symptoms, it's not wrong to try an antidepressant. The likelihood is that it will do something. And as long as they take it, of course, on a daily basis, which can be a challenge with people who use substances, but it's always worth trying it. Antidepressants are so safe compared to other medications we might use that it's always worth giving it a shot if you have a patient that does meet criteria for a major depressive episode. Let's go to the next poll. Other questions I get as a prescriber in concurrent disorder, especially with my psychiatry background, is what do you do with anxiety and insomnia? A lot of patients that use substances, so this is not just for AUD, it could be for any substance use, struggle with anxiety and insomnia, not necessarily related to alcohol withdrawal, but that's the reason why they tend to use. So what do you do? What is okay to prescribe? Again, you guys don't have the choice to pick as many as you can, so you can pick one if you'd like, and then we'll see what the majority says. All right, let's look at the poll results. All right, a lot of people mentioned gabapentin, so the GABA pentanoid agents can be great to help with anxiety and insomnia, especially there's now first-line indication for pregabalin for some of the anxiety disorders, so we'll talk about that. Trazodone is great for sleep if it's not related to just alcohol withdrawal, and it's well tolerated and not addictive, so I like to use it a lot. And sertraline is a great first-line antidepressant agent, so these were the most popular, and I would definitely be in agreement with those. Can we go back to my slides, please? Is there actually a medication for sleep? I'm not sure what you mean by that, but I mean, technically CBT is the best cure for insomnia, right? Primary insomnia. Although I will use medication short terms to help stabilize their sleep. All right. So my tip number 3 is to not ignore depressive and anxious symptoms. So treat them wisely, meaning don't put on 5, 6, 7 medications. So make sure to not create any polypharmacy situation, but do treat them assertively, meaning don't let them wait until they sober up to reassess or until they're abstinent to reassess their symptoms. Actually treat them as you go along, because often the reason they drink or use drugs is because of their anxious and depressive symptoms. So if you don't treat both at the same time, same goes for PTSD. If you don't treat PTSD ahead of time, then when they try to stop using, they're going to struggle quite a bit. Reminding you of the criteria for major depressive episode. This may be common knowledge for you already, but first make sure that you have a major depressive episode if you're going to treat it with an antidepressant. It may be due in part to the alcohol or the substance use. Cannabis can also induce depressive features, but as long as you meet criteria for MDE, it's always worth a shot to prescribe an antidepressant, see if it can help. So here are some of my suggestions in terms of medications for major depressive disorder. Somebody mentioned mirtazapine for sleep. So if a patient's having trouble sleeping, as well as having some anxious or depressive symptom, mirtazapine can be a great option. The only thing is it tends to cause a lot of weight gain, so it would not be something I'd suggest long-term, right? This could be temporary for 6 months while their sleep stabilizes. I do like using sertraline a lot as an antidepressant. It's quite well tolerated, doesn't cause any major sexual dysfunction or weight gain. Venlafaxine works really well, but there's definitely more side effects with it, but it is a very effective agent. Pregabalin is great if you have any history of generalized anxiety disorder, PTSD, social anxiety, because now it's having more indication as being a primary agent for those things. So I left the dosages there for you as well. And then bupropion is not usually recommended due to the seizure risk and some of the substance, obviously, lowering your seizure threshold. I usually don't recommend bupropion. It also has a rep for being more abusable than the other antidepressants, but my main concern is more the seizure threshold, because I think you could always give it daily if you're really worried about the misuse of it, but you don't want to tack on too many medication that lowers the seizure threshold in patients who use a lot of substances. It also doesn't work great for anxiety either. So it's not my first choice for other reasons. How do you know if your antidepressant's working? I suggest using a scale. So the quiz is the one I told you I use. I showed it to you a little bit earlier. These would be the numbers you look for to know whether or not it's working. So I would suggest doing some serial scales to monitor for the symptoms, and then you adjust your medication based on that. Somebody asked about combinations, so that's perfect. So this kind of comes, these are some of my recommendations as a psychiatrist. I've been in practice almost 7 years now. So just know, obviously, that you could talk to different psychiatrists and maybe get different approaches. These are the things that I do based on the experience I've had and the training I've had. I do find that, first off, I would continue the antidepressant for at least 1 year. If patient benefit from it, they may require it longer, and that's okay. They're usually well tolerated. In terms of augmentation, somebody said, well, could you combine pregabalin with an SSRI? I tend to stay away from combination or very kind of, I call them kind of the fancy kind of combos and whatnot in patients with substance use disorder, unless they've been able to maintain abstinence. Because I find if you're starting to have to tack on different agents, probably the substance use is what's causing them to have limited response, right? And you could continue just tacking on agents and not get a good response, and then you might end up incurring side effects or kind of increased risk with mixing substances and medication. So my usual guideline is I try something in monotherapy, and then if it doesn't work, I can try a different agent, but I try not to combine too many things unless I'm using something for something else. Like you could do pregabalins for cravings, and then you could do like your sertraline for your depression and anxiety symptoms. And that would be okay, right? Because they're doing different functions, but I don't tend to augment two agents that do the same thing or are for the same reasons in substance use disorder. I also don't recommend the use of benzodiazepine for treating anxiety and or depression in patients with substance use disorder because of the risk of misuse and respiratory depression. Now, with that said, I've used them acutely for withdrawal in the community, like with supervision from family and friends, or I've used gabapentin instead, for example. So I'm not saying that you can't use benzos at all. What I'm saying is to be cautious if you use them, is to use them short term to make sure there's a good supportive environment to minimize the risk of diversion or misuse. Long term, there's no indication for benzos long term. And if you look at any of the Canadian psychiatric guidelines, it's nowhere in the guidelines that you should be using them long term. For sleep, my first go-to is actually melatonin. If that doesn't work, then I go to trazodone. And then after that, if those two don't work, that's when I'll consider maybe low dose quetiapine, which somebody mentioned in the chat, or the mirtazapine, right? But these medications has more risk of weight gain and side effects, right? So if you're going to that, you need to make sure it's going to be short term. You need to make sure that they are aware of the risk of weight gain, metabolic side effects, and that somebody's monitoring them, right? I've had patients gain a lot of weight on low dose Seroquel, and then that's not good either, right? That doesn't help for their self-esteem. It doesn't help for their depressive symptoms. So it's just important to balance those out. And I always suggest trying to do some CBT for sleep as well. So making sure that they're working on their sleep hygiene, right? There's a lot of non-pharmacological options as well. My talk is about prescribing today, but of course I would make sure that they're getting psychotherapy for any of these reasons, right? Depression, anxiety, cravings, alcohol, substance use, right? Really important to combine it. All right, we have my last poll now. We're going to talk about something that people don't like to talk about, drug-induced psychosis, because it gets everybody going like, ooh, probably what I'll hear about later today. this is the most important part of this talk. Yeah, this is my entire life these days, right? The incidence of drug-induced psychosis have just been soaring and everywhere in Ontario. I talked to my colleagues down south. I talked to my colleagues up here. It is so prevalent. So can we see the results of the poll? All right. So most people said antipsychotic medications followed by benzos. And the reason why I created this poll, and you can go back to my slides now, thank you, is because I went to CSAM last year, and they showed a lot of studies that actually demonstrated that benzos alone are actually great at treating drug-induced psychosis, and specifically men-induced psychosis, and that most of the time we probably don't need to actually tack on antipsychotics as well. And the benefit of not using antipsychotics, and this is coming from a psychiatrist who uses antipsychotics all the time, so remember that, but the benefit would be that there's less risks around QTC prolongation, less risks around lowering the seizure threshold, especially if there's other substances on board that you're not aware of. So there are some benefits to having the benzos be the first line of defense for men-induced psychosis, and a lot of studies are showing that that is sufficient to treat the majority of the symptoms of psychosis with drug-induced psychotic disorder. So I just thought I'd mention it because it's something that I would not have thought of unless I heard it at CSAM. So I thought it was interesting. So yeah, so I'm going to give you some tips that I have on how to tackle our nemesis, drug-induced psychosis, which is very prevalent these days. So first, I have 2 slides on cannabis use disorder and amphetamine use disorder, just to give you a bit of ideas about how you can tackle those disorders. There's no approved medications for either of those. So cannabis use disorder, if you have drug-induced psychotic symptoms or acute withdrawal symptoms, I usually go to non-specific supportive medication like benzodiazepine, antipsychotic medications in low dose, and any of the sleeping aids I already mentioned. There's no approved medications for cravings and cannabis use disorder. Some of my colleagues have been using the, I can't say that, the N-acetylcysteine, which is the antidote for Tylenol overdose. And it's showing promise in the studies. I haven't used it personally because most of my practice, I see patients with either alcohol use disorder or opiate use disorder, and they usually don't want to tackle their cannabis use. They usually want to work on the other ones first. But I've had some of my colleagues recommend that to some of their patients. There's nothing officially approved, though, for cravings for cannabis use disorder. And same with stimulant use disorder. Again, nothing officially approved. I use the same arsenal of medication, but I just told you about the study showing that benzos alone might actually be enough to target the psychotic piece. There's no approved medications for cravings again, but there's a lot of studies that are being looked at as to how could we help. There's studies being done across the country about could we actually administer supervised psychostimulants, for example, to try to curb the cravings for stimulant use disorder. Nothing official yet in guidelines and whatnot, but there's a lot of studies around that right now, right? What if we actually did some harm reduction and prescribe some of these things? So far, there's nothing that's come out that's officially saying, yes, that's what we should do, but be on the lookout. A lot of people ask me, do you prescribe psychostimulants to people who have a stimulant use disorder and they tell you they have ADHD? And that is a common question I get. And in my opinion, unless you have an objectified diagnosis of ADHD in childhood, because remember, it's a neurodevelopmental illness, it makes it really hard for me to say, yes, I'm going to give you a psychostimulant, knowing that you've been abusing all these substances, right? With no good way to monitor that you're not going to use speed on top of the medication I'm giving you, right? So it is a bit tricky, and I tend to not do that. And when I asked other doctors at CSAM last year, they said that was the same. Hold on, I'm just going to hang up. Sorry about that. They also said that that was the same thing that they were doing. Okay, sorry. They were also not prescribing psychostimulant just for the stimulant use disorder unless they had a clear diagnosis of ADHD that was documented in childhood. They are trying to look at vaccine to help with stimulant use disorder. There's this cocaine vaccine that was very talked about, but unfortunately what's happening is, while it worked and it actually was eating up the effects of the cocaine, if people were using cocaine and they had the vaccine, what people did is it just ended up escalating their use of cocaine to get over the immune system and essentially still get effects from the cocaine. So essentially it was not looking promising, unfortunately. So, and I see some people are using the NAC already. They find it works well. Yes, if you have information about dosages, I know you can get it over the counter, the NAC. So if you have suggestions about dosages. I'm not familiar with it, so that'd be great if people write it down. Thank you. All right. Let's talk about drug-induced psychosis a little bit. There's a lot of people that ask me, would I prescribe a long-acting injectable medication to mitigate the risk of drug-induced psychosis? I would say that I've done it myself. And I say some of my colleagues are in either camp. Some of my colleagues are like, never. And some of my colleagues are like, definitely, we should try it. I would say that it would be very hard to enforce a long-acting injectable. For example, for drug-induced psychosis. For example, going to a community treatment order, going to a consent capacity hearing board and saying that I want to force someone to take a long-acting injectable because they keep having drug-induced psychotic episode. I don't think I would have a good case for that. I don't think I would win that. But if the patient recognizes that the drug use is definitely causing psychotic symptoms and are willing to try something to mitigate it, they're not feeling they're able to stop. They want to stop, but they haven't been able to. And if they're willing to take something to mitigate it, then I have actually started them voluntarily on long-acting antipsychotic. And some patients have had good success. One of my patients is an early intervention patient. I do early intervention for psychosis as well, among my many hats here in North Bank. And one of my young ladies used to be in the hospital every couple weeks. I think we were at hospitalization 7 or 8. She would land in seclusion. She was a big methamphetamine user, and she's a very young girl in her 20s. Terrible. She got very traumatized from the seclusion process. Still talks to me about it now, even though she hasn't been in hospital for 2 years now. But I decided, you know what? It's not clear what's going on. Methamphetamine can have so much effects for so long on the brain. I really can't tell. Is there something underneath? Is it just drug induced? I don't know. So I'm going to try it. I put her on the long acting injectable and she has not been in hospital since then. So that's been really good. And she actually stopped using methamphetamine. So now we're tapering her injection over 6-12 months and hoping that she actually won't relapse. So this is great, a great case that shows it can work, but you do have to have consent from your patient to try that. So I have a few of my patients that have been open to doing that. Remember, the methamphetamine psychosis can last quite a bit. So even if the acute effects might be gone in the first few weeks, you can have effects from methamphetamine for up to 6-12 months in the forms of low burrowing psychotic symptoms. So I have a gentleman that used so much methamphetamine, he presented like a dementia. He's in his 40s and he presented like a dementia picture. And we were looking at long-term care because of how bad his use has been, how much his brain has been affected. And it took a year in hospital before he started actually lifting from that. And then we were able to move him to one of our rehab units in hope of diverting him from long-term care. But that was a full year without methamphetamine, right? So it just shows you how severe the impact can be for those very significant users of amphetamines. There's no guidelines that tell you what to do in this area. So what I would say is have a good discussion with your patient about the pros and cons of being on regular medication to mitigate the risk of drug-induced psychosis, especially if they tend to come in regularly. If you don't have that inside piece, it makes it a lot harder. Like I said, in Ontario, I've not heard of so far, and maybe if there's psychiatric colleagues on the line, they can let you know. But we haven't had success here in winning kind of boards saying that a patient should be on a community treatment order for drug use per se. We usually will win it if there's a suspicion of schizophrenia, right, or schizoaffective disorder. But I've definitely seen improvements in their disposition if they can actually go with the long-acting approach because it helps mitigate some of the drug-induced symptoms. My last 5 minutes, I just wanted to, before we go to questions, I wanted to just give you some last tips. So about being kind of a smart prescriber. I wanted to talk to you about routine investigations I tend to do. So when I see a patient for the first time, this is usually what I try to get done. And the idea I have in my head is, I might prescribe an anti-craving, I might prescribe an antidepressant, I might prescribe a low-dose antipsychotic medication to help with sleep, right? So I think about all these things, and that's why that's the profile that I use myself, so that I'm ready for any eventuality, right? Whatever medication I end up prescribing, I've got my baseline blood work. I also try to rule out causes that are reversible of low mood, like anemia and thyroid problems. I wanted to put a plug in about drug screening. I think if some of my residents are on the line, they know that I'm very strong about drug screening. It can be very helpful, but just make sure that if you're using drug screening, you know how to use it properly. So make sure you use a urine analysis with it to make sure that it's valid. I've had so many patients that either consciously or unconsciously have tampered with their drug screen just by drinking too much water or trying to substitute it. And if you're using a drug screen, make sure that you use the results from it. There's studies that have shown that even though some prescribers are given the information about the drug screen, for example, in one study about opiate prescribing, they were told that their patients were actually not using their opiates properly in their drug screen, and yet they still didn't change their prescribing habit out of it, right? So if you are using drug screening, which can be a very helpful tool, make sure that you actually follow up on results that don't make sense with what you're seeing. And I have a handout on my website about drug screening in more details if you want to know kind of which tests you can order, what are the cross-reactivities, false positives, things like that. It's not exhaustive by any means, but it's a 2-pager that can help you in your practice. Keep in mind most substances stay in your body for 1 to 5 days. Some of them will stay longer if they're liposoluble. So cannabis and diazepam, for example, will stay longer. PCP does it to some extent, but we don't see a lot of PCP regularly in my area. But most of the other substances will go away pretty quickly, so you may not catch it on your drug screen. And also there's certain things you can't test with urine drug screens, like inhalants, for example, which you wouldn't actually know then if they're using them or not. So just remember it has limitations, but it can inform your treatment planning. Quickly about QTC, people ask me which antipsychotic is safest. For example, if I use it in acute psychosis from methamphetamine. So if you look at the studies, ziprazoline is the worst for QTC, but that's okay. We don't usually use it acutely anyways. Quetiapine is also one of the worst offenders for QTC, although of all the atypicals, there isn't a lot of effect on the QTC, so not a reason to not use it. Just letting you know that acutely, if somebody has a longer QTC already, you might not want to use quetiapine. It doesn't have an injectable form anyway, so you probably wouldn't, but I'm just letting you know. Haloperidol, risperidone, and olanzapine, which all use acutely, are actually quite good and in the middle in terms of QTC. And aripiprazole, if you do use it in your practice, has very low impact on the QTC. And then I wanted to end with some COVID considerations. So just remember during the COVID pandemic that people may either stockpile medication and substances and have more access, or ironically, on the other end, may also have their usual supply either of medications or substances restricted. So they may end up moving or transitioning towards different drug use during the pandemic. And therefore you may have missed something if you don't ask them whether or not that's changed for them. And they may not take their medications as regularly if they're fearful to go to the pharmacy or to go to see their doctor. Some patients also have turned more to non-beverage alcohol, like rubbing alcohol, to relieve withdrawal rather than using regular alcohol. You also have to remember that the paraphernalia that patients are using can actually also elevate the risk of COVID transmission. So we have to kind of keep all that in mind during the pandemic. From a prescriber standpoint, I do find, especially with alcohol use disorder, that it's a great time for us to talk to them that, you know, most substance use and especially alcohol use will lower your immune system. Therefore, it's a great time for you to look at stopping to use. Just keep in mind that stopping alcohol cold turkey is actually quite dangerous. Same with benzos, you can have a high risk of seizure. So you don't want to encourage them to stop abruptly, but it can be a great conversation starter. Have you thought about how your substances may impact your possibility that you will end up getting COVID-19, and therefore maybe a way to kind of motivate and then move people from pre-contemplation to contemplation or action. All right, so that's the content I have. I'm going to leave the rest for questions. Now, there's been a lot of chat, so I don't know how we're going to, Katie hopefully has been getting some teams so that we can do a bit of discussion.
Time. There's been a couple questions about.
Before you end, I'm happy also to answer questions via email or to take the chat log and answer it later as well, just so people know. You can always email me if you don't get your question answered. Go ahead.
Perfect. Can you speak to the question about dosing and duration of benzodiazepine use in stimulant-induced psychosis?
Okay, sure. So when I looked at the studies, they were primarily using either midazolam because it can be used IV or diazepam. But lorazepam is usually my go-to myself because I just find it works fast. It's available IV, IM, PO. So usually I'll just go like 2 milligrams at a time. And I can do that like every hour on the hour, right? So, and I don't look at the max. So some people say, well, the max is like 8 milligrams. So if the patient's not asleep, you can definitely go higher. So you could go to 10 and 15, right? And that's okay because again, you're looking for sedation. So if you go every hour and you double check how your patient's doing, you can definitely go higher. I could also, if you're interested, if you email me, maybe I can actually put my email while we're talking. You can actually also, let me see if I can do that. I don't know if I can. You can also do a midazolam protocol, right? IV. And I've seen that in the studies as well, but I unfortunately don't know it by heart, but I could email it to you. But I usually just go with my good lorazepam 2 IM, and I usually do a Q1 hour until they're asleep, right? And then I reassess when they wake up how they're doing.
Perfect. Thank you. Another one. What drugs are being used for crystal meth use disorder?
So in terms of medications, I'm assuming is what they're referring to. And again, as I mentioned, there isn't anything approved officially. We're seeing more and more some people trying kind of more of a harm reduction approach where you're prescribing psychostimulants like Vyvanse, for example, to try to curb the cravings for methamphetamine use. Unfortunately, right now, there's not enough evidence for me to recommend that. Now, if people have studies they want to share, go for it, right? That's why this forum is there. But at this point, I don't do it in my practice because what I found actually is that when I give, as I've tried when patients tell me they have ADHD and it's been substantiated by their family, I've tried Vyvanse, and what's often happened if I use a psychostimulant is that they end up using Vyvanse on top of their methamphetamine or amphetamine use, and it hasn't actually been effective for me. Now, there's multiple factors for it that might be, but at this point, unless we have a clear protocol that's approved, I'm going to kind of hold off and see where the evidence is going to go. I am attending CSAM ISAM this year, so I'm curious to see if they have more kind of recommendations for us. Last year, they recommended not doing that at this point, not prescribing harm reduction kind of psychostimulant to help with methamphetamine use or amphetamine use.
Great, thank you. And I know there's quite a chat going on in the chat box about all of this right now, so I think that addresses some of it anyways. Thank you.
Take that chat for me because I want to read it because I'm so excited. You guys are awesome, by the way. Thank you for such enthusiasm. I really appreciate it.
I'll just try to keep running them off then, the rest of them. Any concerns with benzodiazepine treatment use in developing a revolving door cycle of uppers and downers?
Oh, definitely. It's part of why I'm so careful with them, right? Because I think, unfortunately, when people don't know what to do, right, they're going to go to what feels comfortable, right? So some people will end up using downers, and then, like, I have patients that use alcohol and cocaine all the time, right? The alcohol brings them down, the cocaine wakes them up, and then that's the cycle they have. And definitely, you can contribute to that inadvertently. So that's why I limit my benzo prescribing to an alcohol withdrawal. Or if I have a clear patient that's a primary anxiety disorder and is going to likely get admitted or be in emerge multiple times if they don't have a short course of benzo that's supervised, right? But that is it. And by a short course of benzos for anxiety, I mean like 2 to 3 weeks, no more than that. Past like 3-4 weeks, you develop dependency, right? So you don't want that to happen because then you get into that cycle where they're going to struggle to get off of them. And I try to offer other alternative first, right? I don't go to benzo right away, unless it's alcohol withdrawal, of course, and that's the number one in hospital that I use, or gabapentin, right?
Fantastic, thank you. What are your thoughts on tryptophan for sleep?
Oh, good question. So I've had some of my patients try it. They haven't been particularly happy with it, but I'm not opposed to it. I just haven't seen a lot of good results with it. But when a patient comes to me and wants to try something, I'm always very open-minded. And I also, if you look at the Canadian guidelines, has suggestions for medication, alternative medicines that work for depression and sleep. So you can always look that up as well. And that might give you some ideas of what you can recommend, like St. John's wort and things like that. What I always tell patients is make sure it doesn't interact with your medication. So we either call the pharmacist to confirm, or we look up kind of the medication or the supplement they want to try. And then make sure to do a clear trial, right? If you're going to try tryptophan for sleep, for example, make sure it doesn't interact, that you don't have too many serotonin medications already, right? Because you don't want serotonin syndrome. And then do a clear trial of, like, you're going to try it for 4 weeks regularly every night, monitor your sleep, do a sleep diary. And if it doesn't work, then you get rid of it, right? You don't want to tack on things and end up having interactions. But I'm very open to alternative medicines. I just make sure that it's a proper trial, right? That you make sure that you do it with the patient and you support them in it.
Perfect. just keep going. How concerned are you about Effexor and methadone combined regarding QTC?
I'm not. That's very blunt. I'm not. I would just do an ECG first, and if you ECG, it's fine. So the whole QTC thing, right? By the way, I don't want it to be too hyped up, eh? Like I'm not. I've never had somebody die from QTC prolongation from medication. I've used olanzapine up to like 70 milligrams, right? Like so, when somebody's really agitated, and I've never had anybody had like QTC prolongation, had torsades or something like that. So it's just to be mindful of it. So if you do an ECG and your QTC is not bad on methadone, you can definitely do Effexor. And if you're worried about it, you can always redo an ECG afterwards, right? In a few weeks, just to make sure it's okay. But there's no reason why you can use them together.
Perfect. Thanks. What is the safest anti-craving medication used in pregnancy?
Safest? Well, I think they're all category C except for topiramate, which is D. So I would say that you're good with any of the first line. So naltrexone or camprosate. So category C means we don't think it does anything harmful, but we can't confirm for sure, right? There's no medication in psychiatry except for some reason clozapine is B. And I never understood why, because clozapine has so many side effects. But everything is category C in psychiatry. And we prescribe them in pregnancy all the time, except for the mood stabilizers. These are worse for but I mean, in general, like antidepressants are category C. Most of the antipsychotics are category C, right? So naltrexone and camprosate are in the same camp. So they're fine to be used in pregnancy. Just have an informed consent discussion with your patient, letting them know there's limited studies. But when we look at the pros and cons, right, alcohol is going to do likely worse damage than whatever the naltrexone might do, right? And also make sure they're not using opiates if you're prescribing naltrexone.
Perfect. Our chat is almost up. So I don't know if you want to address a couple last words or if you want me to keep throwing out questions. And we've got about 2 minutes left.
I don't really have any last words. People have my email. People have my my website for extra resources. Contact me, text me, call me. Not in the middle of the night if possible, unless you're really not doing well. But I'm happy to answer 1 or 2 more questions.
Perfect. Can you please comment on dosing of naltrexone and what they meant by that? I think was the higher dosing than 50 milligrams.
Yeah, so I think it was in my slide, right? You can go all the way up to 150. I usually start at 50, and then I monitor, right, where they fall within the drinking guidelines, and then I'll up it by 50 until I hit 150 based on how they're doing.
Perfect. And to follow up on the one someone asked, I understand that naltrexone could also increase tolerance for alcohol.
I don't think naltrexone would. I mean, it decreases the pleasurable side effects of alcohol. So some people could think that they're more immune to it, right? And that they want to drink more to overcome that. But it still will make you as intoxicated, right? So your impaired judgment and all that will be the same. And abuse. So disulfiram, actually, I had a patient who figured out that if she used just a small dose of disulfiram and then a bit of alcohol, she would get extremely intoxicated and have a great high from alcohol. And then we stopped the disulfiram. But then the pharmacist asked me, is that harm reduction? And I was like, because she's drinking less, right? So that was the question. So, but that's the only one where I've seen where it can affect the metabolism of the alcohol that way, right? Naltrexone doesn't affect the metabolism. It just reduces the pleasurable side effects.
Perfect. And maybe one more with a couple seconds left. What are your thoughts about prescribing gabapentin or pregabalin in individuals who are still drinking, at least to some degree?
Oh, I've done it for sure because it works as an anti-craving too, right? And it can also help with the subacute withdrawal symptoms. So it could be a way to start tapering the alcohol over time. So I definitely done it. What I try to be cautious, obviously, is I teach patients to watch for their sedation level, right? I tell them to try, obviously, they shouldn't be driving when they're taking their gabapentin or right before or right after it, right? Be careful, know your body well. And obviously, if they're reporting more blackouts and things like that, then I would just stop it. But it definitely is okay to combine both. You just have to make sure your patient is aware of kind of what they should be doing. They shouldn't be go driving after they take their gabapentin. They should be drinking and driving either, right? So, so just be mindful of that and teach your patient to watch for their own body. But you can use both together because it can help for cravings. So I definitely have done it, and I might just start lower first, right?
Fantastic. Great. That's the end of the session. There should be an evaluation form, I think, that comes up. There were a ton of questions that we missed, so sorry, everybody, and thank you so much for participating. And thank you for giving us such a wonderful presentation today. That was great.
You're welcome. And please find a way to send me the chat, so because then I can answer the questions, or at least I can review them. So thank you, everybody. Have a good rest of the Medify conference. Hopefully I can attend some of it.